All right, thank you very much for the kind introduction and for inviting me to come speak. I'm happy that there is a good turnout after lunch. I know that can be challenging for the last day of a multi-day conference, so thank you all for staying. I think we do have some important things to talk about. I'm going to review kind of where we are right now with multiple myeloma, and I know a lot of you are probably very familiar with this. But then I really want to spend, I think, the latter part of the talk going over some of the recent advances in multiple myeloma that were presented at ASCO this year. And my only disclosures are here. So, as I mentioned, the goal of the talk is to review strategies for transplant-eligible multiple myeloma and also for transplant-ineligible multiple myeloma, kind of highlighting, again, in the last part of the talk, some updates from ASCO. So what is the current best practice for treatment? And I think this is pretty well agreed upon by all the myeloma thought leaders across the country. For transplant-eligible patients, we recommend induction with 3-drug combinations, although I think with the data from the Cassiopeia trial, which we'll review shortly, 4-drug combinations are likely to really become the standard of care once we see the results from the Griffin trial, which was the US counterpart of the Cassiopeia trial that included CD38 monoclonal antibody with standard RVD induction. After induction, we still recommend autologous stem cell transplantation in first remission. And I think the one thing you constantly hear at these conferences is, is this the end of transplant? And I have to tell you that with the IFM-2009 trial, a very large study comparing transplant with induction to induction with no transplant, still showing a significant benefit for autologous transplant. I think we can safely say that in 2019, autologous stem cell transplant is still the standard of care after induction. And then for maintenance therapy, the standard, at least right now, would still be lenalidomide. High-risk patients should receive bortezomib, and I think many myeloma specialists are recommending 3-drug regimens, although that hasn't been studied in a randomized study that's published to date. For non-transplant eligible patients, we consider 2 or 3 drug combinations, followed by maintenance, and then supportive care is a very important element of myeloma treatment, continues throughout. So, what is the data for our preferred upfront treatment approach? This is very well established with the IFM-2009 trial. That was published in 2017 by Attal et al. So that was a randomized study comparing induction with RVD for 3 cycles, lenalidomide, bortezomib, and dexamethasone, followed by autologous stem cell transplant, followed by consolidation with RVD, then followed by maintenance. And that was compared to RVD followed by maintenance alone, showing a very significant benefit in terms of progression-free survival. Maintenance therapy is the standard of care with an immunomodulatory agent, preferably lenalidomide post-transplant for standard risk patients. And then based on the results of the HOVON-65 trial, I recommend all patients who have high-risk cytogenetics, particularly 414 translocations, which are where the data is strongest, to receive proteasome inhibitor-based maintenance post-transplant. And then, in general, I recommend intravenous bisphosphonates for all, although recently the data from the study comparing denosumab, which is a rank ligand inhibitor, to Zometa showed a progression-free survival benefit, which was not the primary endpoint of the study, but is intriguing nonetheless. So we'll hear more about that, I'm sure, in the coming months to years. So why do we use 3 drugs? And again, I know a lot of this data is probably familiar to all of you, so I don't mean to harp on this too much, but really 3 drugs give higher response rates than the old 2-drug regimens that we used to use, as depicted by this slide here. Over on the left, we have the ancient regimen of VAD, which was used prior to transplant in the 80s to 90s. And then with the introduction of proteasome inhibitors and IMiDs, we've really seen improved response rates. As you can see, overall response rates in excess of 90% with RVD, potentially higher with carfilzomib, lenalidomide, and dexamethasone. Although a randomized study comparing KRD versus RVD induction is still ongoing, and the analysis from that is not available yet, and that's the Endurance trial. That was an ECOG study, and I'm eagerly awaiting those results, as that may be a practice-changing study depending on what we see, or not. And further proof of the superiority of RVD was really shown in the SWOG-S077 trial. That was an intergroup trial comparing RVD induction to RD, which was the old standard of care. And RVD showed superior response rates, as shown here, and superior rates of complete response. So there's no question in 2019, RVD is the standard. And this is just the progression-free survival curves here showing a vast improvement in progression-free survival with RVD. So to summarize the data so far, we know that 3 drugs are better than 2 drugs. There's no question. And modern PI and IMiD combinations can overcome some of the traditional high-risk features like deletion 17p or translocation 414, although they don't abrogate those, that disease biology completely. And in terms of, when would I not give an IMiD in induction? I think if a patient had renal insufficiency and they had acute myeloma cast nephropathy, I probably would more strongly consider an alkylator PI combo like VCD, bortezomib, cyclophosphamide, and dexamethasone for at least 1 cycle to try to get rapid reduction in their light chain burden before changing to RVD. And the goal of induction is a deep response. And I think there's some debate constantly about, well, how many cycles of RVD do I need to treat with until I send a patient for transplant? I think, if you go off the IFM data, patients in that study received 4 cycles of RVD followed by autologous stem cell transplant. And those data, I think, would argue that really patients just need at least a partial response. There's no absolute monoclonal protein level where it really matters that much, although I can tell you in practice at the SCCA and Fred Hutch, we usually recommend to treating to the lowest possible monoclonal protein. That's not necessarily evidence-based, but I think there is a lot of variation in this practice. But really the goal of induction is a deep response. Moving on to autologous stem cell transplant, the dinosaur in the room, at least some people are saying that nowadays, that it's an outdated therapy, highly toxic. Well, I think we shouldn't judge therapies by how old they are. People have been setting bones and casts for hundreds of years. Does that make it an outdated treatment? Not really. So why should we consider autologous stem cell transplant an outdated therapy just because it's been around for years? I think that's an illogical conclusion to draw. Autologous stem cell transplant has very low treatment-related mortality in the modern era. I mean, we very, very rarely see deaths on the transplant service. If we did, it would be astonishing. And furthermore, there is very good data that it improves outcomes in all patients, high risk, standard risk, even in the era of modern novel agent drugs like IMiDs and PIs. And as we'll see, even in the era of drugs like daratumumab. At our center, we routinely recommend transplant. I think, in terms of what is a transplant-eligible patient, if you're in Europe, they'll say that 65 is the maximum cutoff for transplant. Here, I think we're a little bit more open-minded in terms of how we consider age as an eligibility. Certainly, probably the upper limit of what I've sent a patient for transplant is 77. But there's good data that transplant is effective even in the elderly population, provided that they have good performance status, low burden of comorbidities, and good overall level of health. So sort of passing the eyeball test is what I like to say. I routinely recommend early transplant because really if you just want to go by the data, you have to go by the IFM 2009 trial. And those patients all received transplant right after induction. They didn't delay. I have to tell you, I've been disappointed with the outcomes when patients delay transplant and do it later. I just haven't seen as good results. And of course, that's anecdotal, but I think if you want to take a data-driven approach, early transplant after induction would be the way to go. Again, we see very low treatment-related mortality in the modern era, and I think even the acute regimen-related toxicities like mucositis, infections, and diarrhea, they're transient, they're manageable, and so I think, this should still be a very important part of our care of myeloma patients who are eligible for it. What about maintenance therapy? So I'm sure you're all familiar with this data. Lenalidomide maintenance would be the standard of care for a patient who has standard risk chromosomal changes. It is shown to improve progression-free survival in several large studies. One study, the Alliance trial, which previously was a CALGB trial published in JCO a few years ago, actually showed that lenalidomide maintenance improved overall survival. So I think that even in the light of the risks of lenalidomide maintenance, which are a slightly higher risk of secondary primary malignancies, the scarier ones being MDS and AML, lenalidomide maintenance, the benefits far outweigh the risks of secondary cancers. So I think every patient, unless there's really some compelling reason they can't tolerate IMiDs, which is exceedingly uncommon as long as you manage toxicities appropriately, every patient should have a discussion about lenalidomide maintenance. And my preference in my practice is to give it indefinitely and not to stop like at 2 years or 1 year like they did in the IFM 2009 trial. Additionally, there was a meta-analysis of lenalidomide maintenance that showed an overall survival benefit with lenalidomide maintenance. So I think it's a slam dunk. Bortezomib maintenance, I think if you go off the data from the HOVON 65 trial, which was a study comparing bortezomib maintenance to thalidomide maintenance, this is a study conducted in Europe, in that study they showed a particular benefit for bortezomib maintenance in the patients with the 414 translocation. Those patients in that study had not only a PFS benefit, but also an overall survival benefit with bortezomib maintenance. The DEL-17Ps had a PFS benefit, but no overall survival benefit. So the 414 translocations where there's really clear data, bortezomib maintenance, and actually I think in practice, a lot of us will give 3 drug maintenance with Revlimid, Velcade, and dexamethasone, sometimes with carfilzomib. And just to be clear, that's not based on randomized data. There was one single-arm study that was published from the group at Emory that showed, I think, very encouraging results in patients with high-risk chromosomal changes or plasma cell leukemia who received RVD maintenance, but there is still no randomized data as yet. And then ixazomib maintenance is really the new, I think, option we have to offer patients based on the results of the Tourmaline-3 trial that were presented at ASH last year. Ixazomib maintenance was shown to improve progression-free survival post-autologous transplant. And so this was a randomized study of ixazomib versus placebo. The ethics of giving a patient placebo for maintenance in the modern era, I think, could be debated because the study was likely designed years ago when we didn't have maintenance as a standard of care. They did show an improvement in progression-free survival for ixazomib maintenance. It may not be quite as good as that we see for lenalidomide, but I still think this is a reasonable option. I have some patients in my practice who can't tolerate lenalidomide maintenance and live far enough away that they can't come in for bortezomib, and in those patients I've recommended ixazomib maintenance. Also, I think it's a good option for patients that don't want to come in, if they do have high-risk cytogenetics, don't want to come in for injections. Ixazomib, I think you could make a rationale for combining it with Revlimid for maintenance, so IRD maintenance. So ixazomib is a new option, definitely something to consider in patients who either can't tolerate an IMiD or just want an option that includes a proteasome inhibitor after transplant. And we talked about this a little bit in terms of transplant eligible versus ineligible. I'm going to skip over this slide because I think we've kind of addressed these concerns. Treatment of non-transplant eligible patients who are newly diagnosed. So I think that slide was meant as a segue to talk about who is non-transplant eligible, and I will tell you, in my practice, there are very few patients that are not transplant eligible. But we do see them, a handful a year, and I think that's just a bias of working at an academic center that we're more aggressive with considering transplant. Certainly in the community, I think it's a far different picture, and we know that the rates of patients referred for transplant or who undergo a transplant in the United States is below 20%. So transplant is underutilized. Nonetheless, there are many patients who cannot undergo a transplant either due to social situations, degree of comorbidities, or just simply advanced age and frailty. And so for those patients, I usually try to consider a triplet combination. So one of the regimens that I commonly use is RVD light, which is really just reduced dose RVD. So we use Velcade dosed once per week. Lenalidomide I would usually start at a lower dose, like say 15 milligrams, and dexamethasone starting at 20 milligrams, because I found that elderly patients really have a lot of difficulty tolerating high dose 40 milligrams of dexamethasone a week. If someone can't tolerate RVD, then I think doublet therapy with lenalidomide and dexamethasone is very reasonable. But increasingly, we have new options, and this is very exciting. Daratumumab, a CD38 antibody, was combined with RD And this was the Maia trial that was presented at ASH last year. And this is now FDA approved as of I think a couple of days ago. Daratumumab is FDA approved. So I imagine we'll probably see it show up on the NCCN guidelines soon, which is really what informs insurance companies. I have treated a couple of patients with daratumumab and Revlimid, and sometimes patients who are very frail, and I've seen, I think, very impressive results so far. Daratumumab plus VMP is also improved based on the Alcyon trial, although I will tell you, nobody in the United States uses melphalan for induction. It's really, I think, something that was largely for Europeans, where they do use VMP more commonly. And then you can consider alkylate or PI combo, so Cybor-D would be the common one, if someone can't get Revlimid for some reason, say their income is above the threshold for getting Revlimid copay assistance. So I do kind of want to spend the last few minutes of this talk talking about updates from ASH and ASCO. In my opinion, the most exciting data that we see from ASCO, and this is not meant to be an exhaustive list since we're time limited, the Forte trial, which was a trial conducted in Italy. It was a 3-arm study of KRD with or without transplant versus KCD. The Maia trial, which I mentioned earlier, daratumumab, lenalidomide, and dexamethasone versus Lendex in newly diagnosed transplant-eligible myeloma. And then finally, I think the most exciting data that we saw out of ASCO was the results of the Cassiopeia trial, which was a randomized study. It was conducted in Europe of Dara-VTD versus VTD in newly diagnosed transplant-eligible patients. The sister study to that is the Griffin trial. That's a study of daratumumab, Revlimid, and Velcade, and dexamethasone versus RVD alone. That study is still ongoing. We don't have results yet for that. But nonetheless, I think this really, the standard of care in the coming years is going to move to including DARA in upfront regimens. So the Forte trial. This was a study that was a study of KRD with or without transplant according to risk status. It was a 3-arm trial. Patients received induction with KRD. Arm 2 and 3 got KRD. Arm 1 got KCD. And then the first 2 arms could get a transplant as part of their treatment. The 3rd arm just got KRD, so a total of 12 cycles of KRD. There was a second randomization after consolidation to receive either Revlimid or carfilzomib and Revlimid maintenance. The primary endpoint of the study was VGPR after induction, and the endpoint number 2 was MRD rate pre-maintenance and rates of stringent CR. So when these data were originally presented at ASH last year, I think there was a lot of murmurs because the MRD rates, the rates of complete responses were really similar between the patients who got KRD12 and the patients who got KRD transplant and then KRD consolidation. And this is where we hear, I swear, every year at ASH, someone that we hear the transplant is dead, and nobody's going to do transplants anymore because we have these great new drugs. But when they presented updated data at ASCO, looking at a more complete analysis of the data, they actually saw that MRD negative rates at 1 year were higher, significantly higher, in terms of percentages, just 4% higher, but higher with autologous transplant. One thing that I think is important is that it's clear from other data that MRD negative transplants are different than MRD negative treatments with KRD or RVD. We see better outcomes in MRD negativity with transplant as compared with MRD negative with novel agent induction alone. So this is a further breakdown of that data. So this is pre-maintenance, 58% versus 54%. 1 year persistent MRD negativity, significantly higher with KRD and transplant, 90% versus 78% with KRD12. So I think it's clear that even though the early data suggested similarity between these, long-term data really refutes that. And this is further shown here, even in the higher risk patients, a significant difference in MRD negativity, 90% at 1 year versus 72% in patients who did not get a transplant. So transplant is still a very important part of treatment, I think, even for high-risk patients. And so Nonetheless, I think there's still good data now. If you have a patient who can't get a transplant, they're getting KRD for whatever reason, and I think there's a lot of variation across the country in why that would happen. KRD12 would be a very reasonable option. High rates of MRD negativity, but I think if you have a young patient who's transplant eligible and you want the best outcomes, 3-drug novel agent followed by transplant is still the winner. The second study that I wanted to mention, and I think this is probably has the potential to be practice-changing or very likely in the near future, was the Cassiopeia trial, a randomized study of DARA VTD versus VTD in newly diagnosed patients. And the study design is depicted here. In the interest of time, I'm not going to go through this since I'm sure many of you are familiar with these data. The post-consolidation depth of response was significantly higher in the patients who got DARA VTD at 93%. 29% of those patients had a stringent CR. Only 20% of the patients who got VTD in transplant had a stringent CR. That was the primary endpoint of the study. So this study met its primary endpoint. We showed that DARA plus VTD improved depth of response. MRD negativity rates were similarly significant higher amongst the patients who got DARA VTD induction and consolidation, 64% versus 44%. I think those are really dramatic changes. The one thing I would note, and that data is not shown here, is, at least not the complete data, is that the high-risk patients really seem to have kind of a lesser benefit with DARA-containing induction regimens. And so I think this will need to be borne out by randomized studies because clearly, there's small numbers here, so it's hard to draw, I think, real conclusions based off these data. But if I had a high-risk patient, I probably would more strongly consider carfilzomib for induction rather than DARA VTD. PFS similarly was also improved from first randomization. 18-month progression-free survival, 93% in the DARA VTD arm, 85% in the VTD arm. And overall survival benefit, interestingly, and these data are not mature, overall survival seemed better in the DARA VTD arm, and this did not reach statistical significance, but I think it's very compelling nonetheless. But these data do need to be interpreted with caution. The study was conducted in Europe, where we don't really have widespread availability of drugs like daratumumab, as compared to the US, where we do. So I think until we get further data, this should be regarded as exciting but preliminary. Finally, the Maia trial, which many of you are also familiar with, the study of DARA-RD versus RD for induction, was recently reported in the New England Journal of Medicine, and then as of 2 days ago got FDA approval. This was a study of DARA-RD versus RD for transplant-ineligible patients. This met its primary endpoint. It showed that there was a dramatic improvement in progression-free survival at 30 months, 71% of patients versus 56%. So I think, this is a really exciting era for multiple myeloma. There's many new options. We're really starting to see CD38 antibodies moved into the frontline setting. DARA-RD is now approved for transplant-eligible patients with newly diagnosed myeloma. And I think in terms of, I think the trouble with DARA-RD is we have RVD, which is an excellent regimen. Patients only get Velcade for a limited amount of time. In the Maia trial, patients got daratumumab continuously. So I think we should be thoughtful about who we recommend DARA-RD for, although I suspect that across the country we're going to see a lot of practices moving to DARA-RD for induction for transplant-eligible patients. For patients that are transplant eligible, 3-drug regimen followed by transplant and maintenance is still the gold standard. And I think 4-drug regimens or quadruplet therapy are going to really become the standard of care in the coming months to years. And then autologous stem cell transplant is still very important, even in the era of all these exciting new drugs. Transplant is something that dramatically improves progression-free survival for patients and should not be excluded as an option. So with that, I'll finish up and have time for questions if there are any.
All right, any questions? So something like cyclophosphamide-based regimen, is there a specific multiple myeloma situation when you'd consider that as a front line compared to other regimen?
I think if a patient, there's a couple scenarios where I've used it. One, a patient who can't get Revlimid for a number of reasons. And so in our practice, we have people who are undocumented in the country and they cannot get Revlimid. So I have treated them with cyclophosphamide and bortezomib. The other situation is if someone is above the income threshold, so they have to pay out of pocket for Revlimid, and then I've given them cyclophosphamide and Velcade. The other situation where I've had to use Cyborg-D is if patients simply cannot tolerate an IMiD. And I have some patients. This is very uncommon. I mean, usually the rash that we see with Revlimid can be managed with dose reductions. Neutropenia can be managed with dose reductions and maybe G-CSF. But to be sure, there are definitely patients I treat with cyclophosphamide. It's just not as common now.
Sure. Do you see any second primary malignancies with Revlimid?
I have not, but I know many in my practice have. I think I just haven't followed patients for long enough. Clearly, they're going to happen. I'm just waiting. I know statistically, 6 to 8% of patients are going to get a secondary malignancy. I'm just waiting for when it will happen because I see enough patients that eventually it will.
Can you expand on your comment when you were talking about DARA plus RD in the transplant ineligible?
Yes.
Versus RVD up front. You're weighing those two considerations?
Oh, so I think this is something, there's no direct head-to-head comparison.
Right.
So we don't, I think, obviously if a patient has severe neuropathy or, then I would probably consider DARA RD. That's a clear-cut reason. But otherwise, I think, I probably will continue to use RVD for most patients because that has the best data. There's a limited duration of Velcade, and then we stop it. And I think, without randomized data, we can't answer. But I suspect that DARA RD is going to be used more widely for reasons that probably have to do more with reimbursement because of the 6% that you get for chemo on top.
It is not 6%, by the way.
How much is it right now?
It is around 4% or so.
But still, if you're talking about a drug that's...
I know, I'm aware. I see Vincent Rajkumar's tweets all the time.
Yes.
And he should correct that. He should change that. It is not 6% anymore.
So, but even at 4%, I think it's enough.
That is substantial. I totally agree. I'm with you.
Okay. I guess if cost was no matter, and I guess, the debate about whether doctors are supposed to think about cost, some of my colleagues tell me don't think about cost, that's not our job, but I disagree. I think, these all drugs that are given result in effects to the insurance system and the premiums that we pay, so I think we have to think something about that. We cannot just ignore it completely.
Absolutely. Access to care, that's
Exactly.
Yep. Any other questions? Yusuf, you have any questions? No. Perfect. Well, thank you so much, Ed.
No, absolutely. Thank you for having me.
So, second part of this session, I will invite Sherilyn.